So, do you want us to start? I want you to express your wants and needs.
Yes, let's go. Let's do it.
I don't want to start at all. We are episode 7, right?
Yes.
Hi, welcome to Outside the Loops. I'm Ari Haberberg. I'm here with Dr. Katie Weichman and Kimberly Amoroso, a certified genetic counselor, to discuss that very important step in your breast cancer journey. Katie, tell us a little more.
We know, and we've talked about this in other episodes, that the general population has a risk of about 12%. So 1 in 8 women up to the age of 70 could get breast cancer. That's the 12%. But the reason patients are coming for genetic testing and genetic counseling is because certain genes have higher risk. And certain patients may be referred to you from the breast surgeon because of their risk is higher. And as you mentioned, that can include their age, their type of cancer. I think we've talked about triple negative in the past. If they're a male with breast cancer, if they have a significant family history, and we're going to talk about that a little bit more. So when the patients come to see you, what can they expect? You had mentioned that it may be a video visit first with a consent form and then testing and then a visit afterwards. But how long does this take? What time frame? What can they expect?
So there's a couple of ways that genetic testing can happen. The first is our expedited protocols. So these are patients that are meeting with their breast surgeons, and their insurances allow genetic testing of this way. And they are watching a video and signing a consent form with a genetic counseling assistant. She's generating a pedigree, which is a family history. So that's one way that patients can have genetic testing. Certain insurance companies prefer to have the patients meet with a genetic counselor prior to starting the testing. And other times, patients may have outside genetic testing and they're coming for interpretation. So there are, at least three possible ways they can arrive in my office or initiate the genetic testing. I think for most patients, when they meet with a genetic counselor, there are 3 main components of what will happen. So first, I will review the history. So I'll review the patient's breast cancer history. I will review her other medical history. A lot of the times I've taken it out of the medical record. And so I'm just confirming the diagnosis and going from there. The second, I think, most important component is the family history. So what cancers are in the family? Is there a family history of multiple individuals with breast cancer? Are there prostate cancers? Is there an ovarian cancer? Is there a pancreatic cancer? Those are all red flags for some of the breast cancer susceptibility genes. The third part is the informed consent part. And that is where I go through what genetic testing is. I go through the types of results that can come out of genetic testing. I go through some of the medical decisions that can be made based on a positive genetic test result. I kind of give them this is the possibility, so that when they get a positive result, and most patients aren't going to get a positive result, but so when they get a positive result, they already know that this could influence my surgical decision for my breast cancer, and this could definitely impact the need to have a oophorectomy or removing of the ovaries and the fallopian tubes, because many of the breast cancer genes also have ovarian cancer components.
Not to oversimplify, but I want to find out how susceptible I am to further cancers, to other cancers.
Only 10% of patients about have a genetic link to their breast cancer, a genetic abnormality, about 10%. But it may, as Kimberly said, change their treatment. So if you have the BRCA mutation, for example, you may choose to have both breasts removed because your risk, if you have one cancer, that your risk of getting a second cancer is high, and and then also you'll want to get your ovaries removed as well. So that's the reason.
Okay. Thank you.
Yeah, so I think that many patients come in to see a genetic counselor because they want to know why they developed their first breast cancer. And so potentially we can find a genetic cause. But I often tell patients the genetic testing is more about your future risk for cancers and the steps you can take to either catch a cancer at an early stage or actually reduce the risk to develop cancer. So it's not a lot about, now there are some targeted treatments. So, this could influence their current cancer. But to me, it's more about their future cancer risk. We do know that patients that have BRCA or other breast cancer susceptibility gene mutations, we do know that it can sometimes influence the treatment of their current cancers. So we have a lot of targeted therapies for individuals that have, we call them germline genetic mutations.
I think this is a good time to just take a sort of a bigger view and just talk for a second, or won't get into the weeds too much, but about what genes are and what are we testing for. So uh, genes are just, Kimberly, do you want to tell us?
Yes,
Tell us a little bit about genes.
absolutely.
Yeah.
Primer.
So we we get half our genes from our mom and half our genes from our dad, right? And so we all have a whole group of genes that their job is to protect us against cancer. And the genes protect us by making proteins. So what we're looking for is, do the cells have the appropriate cancer protection that they need? A lot of the genes are DNA repair genes that are involved in cancer susceptibility. So does a person have the appropriate, I talk about military personnel. Do you have the appropriate military personnel protecting your cells? Because as our cells divide, they do get damage. So we have a group of proteins that can come in and repair that damage. But for people that have an inherited mutation, it's like they have 50% less of their personnel protecting their cells. So they get cancers at a younger age and more frequently because they don't have the appropriate protection that they need.
Okay, that's very clear.
Yeah, because remember, cancer is just disordered growth of the cells. It's unregulated growth. And so these are the ways that's what cancer is. So
Gotcha.
that was really clearly
Yes,
put.
thank you. Thank you.
That's my job as a genetic counselor.
That's incredible.
Well, now I feel everyone should see a genetic counselor, regardless of whether or not they're in any kind of jeopardy. I'm not even kidding. I mean, it's,
So you're testing for these genetic mutations in these certain genes that are that can be sort of not working as well due to the mutations. So that's what you're going to be testing for. When the patients come, is there what generation should they be like? Should they be talking about their parents, first generation, second generation? Long should they prepare their sort of family history? Because I think it's sometimes you're like, well, and what cancers are important? Are skin cancers important? Is everything important?
Yeah, sure. So the National Comprehensive Cancer Network, the NCCN, has very specific criteria, for example, about genetic testing. And usually they will include up to third-degree relatives. And many health insurance companies will default to the NCCN guidelines for coverage. So it can be obviously first-degree relatives, mom, sibling, kids, aunts and uncles. It can be great aunts and uncles. Those are third-degree relatives. It can be cousins. So as much information, extended out, even to fourth-degree relatives sometimes can be helpful. And really, it's any cancers, but particularly for breast cancer patients, we're focusing on, so like the BRCA genes protect against breast cancer, men and women, prostate cancer for men, ovarian cancer for women, pancreatic cancer. There's some evidence for gastric cancer. There's some evidence for melanomas. So really, any of those cancers should be included. But I think the important thing is really to be fully comprehensive, because let's say that the genetic testing comes back negative, right? Which most people, 90%, are going to come back with no gene mutation identified. It's the cancer history that's going to dictate what needs to happen for cancer surveillance in the future. So if a father has had colon cancer, for example, it's a woman has breast cancer, dad had colon cancer, even though we didn't find a cause for her breast cancer, she's going to need to start her colonoscopies earlier because she has a dad who had colon cancer. So that's where it can be useful for determining somebody's risk for a mutation, their eligibility for a mutation, but also then on the back end, when they're negative, it can help us guide cancer surveillance for that individual patient.
Is ancestry important when thinking about like where you came from, like Eastern European, special sort of certain sects of people? I know that the Ashkenazi Jewish population has a higher risks of a lot of cancers. Is that important?
Yes, it's true that individuals of Ashkenazi Jewish ancestry or Eastern European Jewish ancestry do have a higher rate to have a BRCA founder mutation. There are 3 distinct mutations that are very old mutations, and they do have a higher risk to carry one of those mutations regardless of family history. Many isolated populations do have founder mutations. But I think beyond that, the ancestry can sometimes be helpful if we find uncertain results. And that can help us. I know we haven't talked about uncertain results yet,
but we can go there we can go there right now. You had mentioned there's a couple of outcomes. There's 3 outcomes of the genetic testing. You'll have positive for a mutation, negative for a mutation, and then there's VUS. Can you explain what VUS is? That's very, very confusing to a lot of people.
Sure. So a variant of uncertain significance. So this is where we see a change in the gene, and it's usually a missense change, meaning that it's one letter that's different. Not always. Not all uncertain results are missense mutation variants, but most of them are. So it's just a single letter change. And the problem is when we're looking at a person's DNA, it's being compared to a reference range. And most of the reference range comes from Northern European Caucasian ancestries. So if someone has a different ancestry, their rate of uncertain results is going to be higher because we're not using the correct reference range. So as we test more and more people of more diverse ancestries, we're going to hopefully not have so many uncertain results. And so when I'm counseling a patient and I'm talking about the risk for an uncertain results, I can guide it a little bit by their ancestry and how likely they are to have an uncertain result. And I can focus more of my time talking about most uncertain results are completely benign. We don't take clinical action, we don't make medical management recommendations, and we don't test other family members because 95% of the time it is a unique change, maybe based on someone's ancestry, that is not disrupting how that gene is functioning.
Is there a time as we're gathering more data, you have detected more sort of genetic variants that some of these VUSs could come to a pathologic mutation? Is that something that happens?
The reason that it's an uncertain result is because we don't have enough evidence. It hasn't been seen frequently enough. The American College of Medical Genetics actually has weighted algorithms that laboratories can use to classify variants. And sometimes the weighted algorithms give different results. So one algorithm may say this is deleterious to the ultimate protein product. Some may say it's tolerated. So there's different levels of evidence that laboratories need to utilize. It's very standardized in order to determine whether something is pathogenic or benign. And so there's other things like how conserved is that DNA region across species, whether or not it's been seen, like what families have this variant. So is this variant been seen in families that have ovarian cancer and it's an ovarian cancer gene? That family history may weigh in that algorithm. Also, the location, is it a hotspot location, the type of change that it is. So there's all these different classifications, and each laboratory has its own classification. They use these guidelines, but they have different weighted algorithms that they use. So, yeah, I forgot what the question was.
You answered it.
No, but
I think it's it.
But it strikes me: are we still in the frontier stage of this science, such that there is so little? Are we still in need of more data?
Well, the problem is that we don't have very diverse reference ranges.
Right.
Right. And so that is a huge hindrance. And so I think that once we're testing more broadly, more different, ethnic backgrounds, ancestries, I definitely think that a lot of these variants of uncertain significance will be resolved.
Mm-hmm.
It's just a matter, in my mind, of the diversity of the pool that we're comparing to.
I think this is a good segue into talking about what goes into the informed consent for this. So testing your genetic material, having your genetic material sort of sequence. I imagine people are reticent to have that done for fear it can be used against them, either by larger government, etc., or insurance companies. That's the big worry. And so I guess there's going to be a couple questions, but how does that informed consent process go from your end?
So, as far as the protections that are in place for health insurance and employment, there is federal regulation. It's called GINA, the Genetic Information Non-Discrimination Act, and it protects health insurance companies from utilizing genetic information to change premiums, to drop patients. So, health insurance is completely protected. Also, employment is protected. So no one can use a genetic test result to fire someone or make any employment decisions. So those two things are completely protected. What's not protected is anything else. So like life insurance, long-term disability, those things don't have federal protection. And it can be a concern for many young people, particularly if they are unaffected with cancer. So we haven't yet heard of significant insurance, like life insurance, long-term disability insurance discrimination based on a genetic test result. The important thing to know is that as medical providers, we would never release any of that information to a life insurance company without a patient's explicit written consent. But there's a theoretical risk that a life insurance company could request someone's entire medical record. And if the genetic test result is the only red flag, then it is a theoretical risk that could be used against someone to either raise a premium or not even give a policy. It's all theoretical, though. And this is mostly I'm talking about for patients who are unaffected with cancer. For patients that are affected with cancer, that's most likely the cancer diagnosis itself is going to be the biggest, red flag for the insurance company. But I think that when it's a theoretical risk at this point. So when a patient is, coming up against, well, I don't want to do this testing because I don't have life insurance. Okay, go get life insurance and then come back, because this is a potentially life-saving information that you're going to get versus this theoretical risk of life insurance discrimination.
Don't HIPAA laws come into effect to protect people's information at some point here?
Well, HIPAA protects against disclosure of information to outside agencies, but most life insurance companies will require patients to either submit their medical records, do an ongoing review of their medical records. And so if a patient says, okay, they sign a HIPAA release form that my life insurance can get this information, then that's what it will be. New York State actually has very specific protections against releasing genetic information. There's a very specific HIPAA release that needs to be signed for patients' genetic information to be released. It's considered as an other in the medical record.
Yeah, where it's not even the test results aren't stored in test results, are they? Or where in the medical record?
That's my question.
They're stored in like a way that it's hard to find them sometimes if you're don't know where they are. Is that correct?
We are using Epic now, and the genetic test results are usually readily available. I don't know how everyone's Epic works, but we have a lab tab, and usually the genetic test results are there. Our previous medical record system, we did have a genetics folder that was specifically for genetic test results, the genetic notes, the family history, that was all stored there. But I don't know how, where and how the information is stored across.
Sure.
All non-Epic users.
Or all medical record,
Or all
electronic
medical
medical record systems.
I have a question. Just from the perspective of a patient, what is my experience with you like? Like, what is a visit with you like? Like, what would I expect?
Well, first I'm going to try to make you smile, right? Because cancer can be hard, and genetics can be hard, and my rapport with you is my top priority. And so that's number one, right? So, and I also feel that if a patient, and I often tell this to my student, if a patient starts to spiral and they get very upset, they're not going to hear the information that I'm providing to them anyway, right? So my first step is to make you feel comfortable and to have you be in a relaxed space. And then I introduce the topics of genetics, and then we talk about what the genetics could mean, what it could mean for the patient, what it could mean for the family, and then we go from there.
How long would you say the appointment takes, the first appointment when you're seeing the patient first? About an hour, maybe less?
It depends really on how much information I have going in. It can take an hour. It can take 30 minutes. It depends on the patient's questions. It depends on where they are in their cancer treatment. So there's a lot of variables, but I would say 30 minutes to an hour is a good estimate.
When I went through this, I met with a genetic counselor, and I remember I sort of maybe blanked it out though, but I remember there was like options. There was like tiers. So I could test the genes associated with hereditary breast cancer. I could test more genes than that, an expanded panel of other hereditary cancers. And then there was like a bigger even swath of genes. And so is that something you discuss? Is that something that people can expect?
So recently, in the last couple of years, Memorial Sloan Kettering, based on some data we had from our impact test, which is a somatic and germline test, we decided to move to a broad cancer panel. So our cancer panel is now 94 cancer predisposition genes, some of them being associated with breast cancer and a whole host of them not being associated with breast cancer. And I do talk with patients about, like, this is our panel. we can find something incidentally. So we've learned from our impact studies that family history is not a great predictor of what you're going to find genetically. So we've moved to these broad testing panels. And a lot of times patients don't have information about their family history. Maybe they're estranged. Maybe cancer is just not something that's discussed. A lot of cultures, it's not something, it's a taboo topic. So we can't rely on the patient's report of what the cancers are. I should say we try not to rely. We want that information, but we don't use that any longer to make a decision about what to test for. Of course, if a patient would like to do a smaller panel of just the breast cancer genes, we can accommodate that request. But we are, for the most part, encouraging patients to do the full gene panel. And we do talk to them about finding a cancer predisposition gene that is not evident in their family. And we talk about, the pros and the cons of that. So we do have that discussion. It's an incidental finding, but that patient would still be subject to surveillance according to that particular gene and the cancer risks associated.
What would you say is a common reason people decide after meeting with you that they don't want to go through with this genetic testing? And what percentage would you say, just offhand, that happens, that you meet with them, you discuss it, and they decide they're not going to do it?
So I would say it's a very small percentage of the patients that I'm seeing, but it's a very biased population because patients aren't coming to see me if they're not interested in doing genetic testing. So it's a self-selected bias. So of the patients, I would say most patients, if they're sitting in my office, they do go forward with genetic testing. I've had a couple of patients, this year that have been concerned about life insurance. They've been concerned about other family members' reactions. So I have had a couple of cases of patients want to discuss it with their family members. But for a majority of patients, if you're seeing a genetic counselor, you don't have to. But for a majority of patients, if you're seeing a genetic counselor, they're interested in doing genetic testing.
And I would imagine you're even more self-selected because you're at a coronary cancer center as well, where I think everyone is motivated to sort of know the most and get the most out of their
Yes, and now we have more and more treatment options for patients based on genetic testing. So based on their germline genetics, their inherited genetics, and also based on the somatic genetics, so the genetics that are unique to the tumor.
Do you talk to them about the somatic genetics, or just that there's a possibility that treatments can be based on that? Or do you talk about that more?
So we are, so previously, like 5 years ago, I would have said a genetic counselor wouldn't touch the somatic, maybe 10 years ago, wouldn't touch the somatic stuff. But more and more, we're integrating the somatic and the germline together. And often we can sometimes use, if we have an uncertain result, we can sometimes use the somatic data to help us understand whether or not this particular uncertain variant is driving the tumor. So more and more genetic counselors are being involved up front in the conversation between the inherited genetics, the germline genetics, and the somatic genetics, the testing of the tumor. Sometimes patients are actually coming in when they've already had that testing done. And then we obviously go through with, this is your inherited genetics. These are the risks that are going to be important for you going forward in the future. And these are the risks that, we need to have your family tested for. But then also we talk about not per se like the targeted testing of the tumor. That's more of an oncologist's job, but we can explain to them that this genetic testing is unique to your tumor and not something that can be inherited or passed down to your children.
Could I just ask you a little bit about the timeline? I mean, I come in, I want to be tested. You take my blood? What happens? And how long does it take to get results?
So at Memorial Sloan Kettering, we have two ways to do genetic testing, and we have something called expedited genetic testing. So genetic test results usually take about 3 to 4 weeks. We do have this expedited protocol, and it's primarily for patients that are newly diagnosed with breast cancer that are going to use their genetic test result to inform a surgical decision. And so we do have this expedited where we send out to a commercial laboratory, and we usually get the results in 10 days to 2 weeks. So that can be then utilized. Usually it's at least 2 weeks before the surgery. And so patients can then utilize those genetic test results to inform a surgical decision.
So, for our listeners, it's very important that as soon as I think, as Kimberly pointed out, that it's you see your breast surgeon, and the breast surgeon is the most likely person that's going to refer you to see the genetic counselor and to try to make that appointment. If your breast surgeon refers you to make that appointment as soon as possible, so you can get the test results back to get your decision, to make your decision with the most information.
Yeah.
Yeah, informed decision.
Informed decision.
So we've talked about the health insurance coverage of this. Is there any health insurances that don't cover genetic testing? Maybe not the rapid genetic testing. Some you mentioned they don't, but in general, should health insurance be covering genetic testing?
So most insurance companies are now following the NCCN guidelines for criteria. And the way, our physicians are thinking about it is if a genetics professional, if a physician, if a care provider deems that treatment can be altered by a genetic test result, then insurance companies are covering the cost of genetic testing, even if there's no family history, because we're getting into a realm where someone's care may be compromised if they don't have genetic testing.
And the results when they come back we've talked about this a lot also on this podcast, that the results just sort of bling in your phone and you're just sort of left to interpret them yourself, which with the help of AI sometimes is challenging. Is that similar to this? Is this going to bing in your Epic MyChart that you have a new result? And then do you generally have another appointment set up, or what can people expect the discussion to be after the test results come back?
I think this is the case with everything now, that as soon as the report is released, you're getting a ping on your phone. It's in your medical record. That can be for your breast biopsy, right? You're the first person seeing that you have breast cancer. It can be for your genetic test results. It can be for your CT scans. And it's an issue for the providers, I think, because patients will see the genetic test results and they'll start Googling. And by the time I can get to call them to tell them, they already have all of these ideas from Google. And now Chat GPT. And so I usually try to, my patients who have positive results, I usually try to call them same day. So if I'm in clinic with a patient, I'm getting an alert that there's an abnormal result, and I try to call them that same day so that they don't have a chance to Google.
Will I get cancer? Certainly if I test positive for X or Y.
So I like to think of the genetic test results as a risk factor. So, for example, a BRCA mutation has a very high risk for breast cancer, but it's not 100%. And depending on the family, it might actually be, much lower than what we would anticipate. So I think that there's a general number that we have for breast cancer for BRCA. It can be upwards of 70%. But I've certainly come across families where many females in the family have this same mutation and they don't ever develop cancer. So likely there's something else going on for these families. Where one of the new exciting areas of genetics, I think, is going to be polygenic risk score, where we're looking at single nucleotide polymorphisms to try to get estimates of, does someone have a higher risk for cancer or a lower risk for cancer? We had a study that we did with unaffected BRCA carriers to see whether or not they had SNPs that put them at an increased risk or SNPs that put them at a decreased risk, because the ranges can be significant for patients. So we are trying to get to a point where we can very individualize, this is your risk, right? This is your absolute risk. We're not there yet, but we're hoping to get there, because it's really hard to tell somebody, well, I think that you have a 70% chance, but you might not. And for a patient, it's either, for most of my patients, it's either you get it or you don't get it. It's either yes or no. And if it happens for that patient, it happened 100% of the time, right? And so I think the field is moving towards more customizable risks.
Ari, you asked a question about if this gene comes back that you have a pathological mutation on it, will I get cancer? So there's two different types of patients. This is how I see it. And Kimberly, you can tell me if I'm looking at it the right way. But that if you have cancer and you have a genetic mutation, you're already diagnosed with cancer and then you find out you have the genetic mutation, then most likely your cancer is associated with that genetic mutation. But if you just are getting genetic testing for screening and do not have a cancer diagnosis yet, that's a different there are two different things to think about. Because I think if you have a genetic, and there are risks of getting second cancers with certain genes that are associated with breast cancer, but it's just a note to be that theirs are distinct discussion points or distinct entities.
Yeah, I do agree. I feel like patients who have a diagnosis of cancer, looking for the answer to why or the contributors for the cancer can be like part of their genetic journey, right? For patients who are unaffected with cancers, it's a very different situation where we're now looking at what is their lifetime risk to develop breast cancer and what can we do to mitigate that risk. Catch a cancer at an early stage or do risk-reducing surgeries. I think that patients that have a cancer diagnosis, I think that it's all about what their future risk is going to be. So what is your risk for a contralateral breast cancer, or we like to say new primary because it can occur in the same breast. So what is your risk for a new primary cancer? And if you have this higher risk, would you opt to do surveillance, which would be mammography and breast MRI, which is a reasonable option? Or would you like to reduce that risk as much as feasibly possible by having a bilateral mastectomy? And I think that for me, this is where I can put some power back into patients that may be feeling very disempowered by their cancer diagnosis. So here's a piece of information that you can use to make a best surgical decision for you. Both are reasonable options. And so this is a piece that you can make a decision on, because I think for a lot of patients, they're being told, you have this is how it needs to be treated. And this can give them, for most patients, I want them to feel empowered by this information. And that's one of the things that I love about doing genetic testing, being a genetic counselor, is that can we utilize this genetic information to make you feel empowered and proactive about your health, about reducing your risk to develop cancer, about reducing the risk for your family members to develop cancer. That's one of the things that I love the most about being a cancer genetic counselor.
So you bring up another good point. So if you're diagnosed with a mutation, um, in this genetic testing, what do you recommend for your family? Say I'm the patient, I come back, I have the BRCA1 mutation. Who do I go to in my family? Who needs to be tested, or who do I recommend that they get tested?
First degree relatives, siblings, children are for the most part going to have a 50-50 risk to have that mutation. Now, the age of the siblings, using BRCA as an example, if a sister is 70 and she doesn't have a cancer diagnosis, her risk is likely going to be a little bit less. We would still test that sister because, again, we had said previously, not everyone that has a BRCA mutation is going to develop cancer. It's a risk factor for cancer. But her first degree relatives, an individual's first degree relatives, children. Sometimes we can tell just based on the cancer history which side of the family it's most likely to be coming from. And usually we would start with that parent if they're living, or a living relative on that side of the family. Sometimes if both parents are deceased, we have to go out to aunts and uncles. We have to go to cousins. Sometimes we cannot tell which side of the family it's coming from. Even in these large families where there's lots of aunts and uncles and lots of cousins, sometimes it's not really clear which side it's coming from. So usually I will, if that's the case, I will recommend testing the mother first, just because she will have a higher risk, for example, for breast cancer and ovarian cancer than the dad, who may have a risk for prostate cancer and male breast cancer, but his risks are going to be a lot lower.
Are we missing anything else that you think that the listener should know about the appointment, or know about
Their experience.
up to this point? Are we missing anything that we could talk about?
I think many patients come in being very nervous about genetic testing. And look, I wouldn't be a genetic counselor in cancer genetics if I didn't feel like this information can be power, right? And you're born with it, so it's there, and it's just a matter of, can we, test for it? Do you want to test for it? I think that we've spoken a lot about breast cancer, but breast cancer, for the most part, if it's caught early, is really treatable. The ovarian cancer, we're still not great at treating it. And we don't have surveillance for ovarian cancer. So usually by the time it's detected, it's quite advanced. So these patients are coming in and they have breast cancer. That's fine. You're going to make a decision if you have a BRCA mutation about what you're going to do about your breast cancer. The important thing to me is them knowing about if they have an ovarian cancer, because ovarian cancer is still really difficult to treat. And the long-term survival from ovarian cancer, when it's usually detected at stage 3 or stage 4, is not great. And to me, that's the life-saving information that person will walk out of the room with. Like, what is her ovarian cancer risk, and how can she, the option is to remove the ovaries and the fallopian tubes. And that, to me, that's the most important information that she's going to receive coming out of my office if she has a positive result.
One of the things we always say, it always comes up in this podcast, is that knowledge is power. And I don't think we've had a circumstance or spoken to through a discipline where that has been more relevant than what you do and the knowledge that you bring to your patients and the options that you bring to them. I think it's amazing and exciting. Katie, is it the time for us to?
I think 3 questions.
What are 3 questions we should bring to meeting you?
Well, I think for the initial consultation, it's more about gathering information. I think that the questions come in when we actually have a genetic test result in front of us. And some of the questions could be, if there is a mutation, can we look at my tumor? can we see if this is actually the driver of my tumor? And if there's a negative result, again, can we look at my tumor, right? Somatic testing is, I would say equally important, if not more important than some of the genetic test results, right? So how the tumor is behaving, what type of mutations, those can be targetable in most circumstances. There are, several the other question, if there is no mutation, would be, well, what is the residual risk for me to develop breast cancer or other cancers? And what is the risk for my children? So, the genetic test result is one piece of the puzzle, but the family history is also a piece of the puzzle. And so asking questions about surveillance, even in the absence of an identified genetic mutation, is, I think, very important. And the last thing that I would say is that genetic testing is not a one and done. So a patient should definitely ask, when should I come back? When should I check in about whether or not there's new technology, new gene discoveries, new ways to do genetic testing? Because I feel like we have a lot to learn in genetics. And if you do a genetic test result in 2026, we could be doing something completely different in the next 5 years. So I think that is an important question that patients can bring. When should I contact you again?
Those are incredible. Those are really
that's so terrific.
Can I ask one thing?
Of course.
Sure.
I knew.
Do you think all sites are able to look at somatic mutations? Like, I know at Memorial Sloan Kettering, they're able to, but do you think, say, in most sort of large academic centers, or do you have a sense of how?
There are commercial companies that do offer somatic testing. And so, if it's not available at the cancer center, many cancer centers, I think, do have it available. But there are certainly send out tests that can be ordered for patients if they don't have their own in-house somatic and germline testing.
And then is that something, so say a patient had their cancer and treated at an outside, hospital, can this be done later after treatment, after diagnosis? Is it something that can be done later? Yeah, the somatic side of it.
Yes. So if a patient has had surgery outside of our institution, we can request the unstained slides or tumor blocks to do the somatic testing.
I'm not sure anyone would know to ask for that. So it's really incredible.
I feel it's almost an act of taking back some power that you lose in getting a cancer diagnosis. It's such a powerless process. Right? Am I repeating what you're saying? Yes.
That's because you've been listening.
That's
so
the
male.
message.
That's such a male thing
No,
to do.
I got the message.
Like, it's my idea now. Now, like I took it from you because
no, but you got the message.
Yeah,
that's the point.
That's my goal was for you to get the message, right?
It worked.
I'm glad I got there.
Well, we thank you so much for coming, and we learned so much, and we just really appreciate your time and expertise, and it's been very educational for us.
Yes.
Well, you're very welcome. It was my pleasure.
Well, that wraps it up for this episode. We'll see you next time when we discuss having a mastectomy and
implant reconstruction.
We'll see you there.
Thanks so much.
This podcast is for general information purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient relationship is formed. The use of this information and the materials linked to this podcast is at the user's own risk. The content on this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Listeners should not disregard or delay in obtaining medical advice for any medical condition and should seek the assistance of their healthcare professionals.